Welcome, everyone, to the Care Transformation Studio. I am your host, Amber Fencl. Today, we are here as a part of our series, Pitch to Partner, talking about how to implement new technologies inside the four walls of healthcare. And today, I have the honor of being accompanied by Dr. James Barr from Atlantic Health Systems. Dr. Barr is Vice President of Physician Value-Based Programs and also the Chief Medical Officer of Atlantic's Accountable Care Organization. Dr. Barr, thank you so much for being here. Would you mind sharing with our audience a little bit about yourself and your background?
Sure, Amber. Exciting to be here. The background starts trained as a family physician. 32 years of practicing as a family physician. Realized over time that my father, who tried to get me to be an engineer, his influence came through, and I said, "Wow, I need more data about family practice and how well I'm performing." And that led to becoming a data nerd, you might say. And I started measuring a lot of doctors' performances. And then, of course, comes along the patient-centered medical home model, got involved with that for primary care transformation. And then, of course, into the accountable care organization model back in 2012. And at this point, I'm working now, have retired from my clinical practice, but working full-time at Atlantic Health System. We have 3 ACOs that we actually manage. The different contracts, about 11 with different payers. Majority of them have some form of risk. And we manage about 500,000 patients among 3,700 providers. So we've been doing a fair amount, built our own data lake that we house in AWS and really have pushed the primary care transformation very strong, and then integrated into the specialist and the collaborative care models. And from there, it's been a truly exciting and, fortunately for us, very successful endeavor.
That's incredible. You have put a lot of work and a lot of investment, it sounds like, into your data structure, your investment, and really understanding at the lowest level of what performance looks like, and then sharing that back with what I've heard and learned from you. That you all have designed, and that is no small feat. So congratulations to you for tackling that. And it's cool to be a data nerd, I think. So let's jump in. We've got some questions outlined here. So with that, Dr. Barr, what have you found to really be essential and requirement for a successful environment where clinical innovation can thrive? What have you learned and observed, maybe through trial and error, through some lessons learned? What works? What are the elements that you need to have a really successful clinical environment?
And I'll include the things that end up causing the scars on your back and all those too, because it isn't all easy, an easy path to innovation. So let me just cover a few different areas. Number one is something that I think we did very well from the beginning, is with innovation, it can't be a top-down, like this is what you're going to do, and you're going to do it with this tool, and you're going to do it this way. No. You got to start from the bottom up. And that's how we were successful in everything we did. We really went to that fully patient-centered model, and knew that the first touch, the majority of all the patients, are going to be the primary care practice. So the first people we hired were not case managers or social workers, transitional care nurses. They were what we call ACO population care managers. They're nurses trained in practice transformation to drive better quality, better patient experience, of course, affordability of care. So that was the bottom, working up. What's going to help that patient have access? Number one thing, if you don't have access, you're going nowhere. So access was right there at the beginning. What technology, tool, innovation can we use, or data points, to drive the increased access? So these are, if you keep that decision to, okay, what's it doing to start the access? Then when the access occurs, do we get that patient's needs met? Do we also, though, identify the gaps? Yeah, it could be coding gaps, quality gaps, other gaps. Do we assess the social determinants? So you just keep building from the access point and up. And we found that in our data, the number one determinant of our success every year, when you looked at all our practices, which was the most successful doctor, who was the best practice, it was the one who had the most PCP visits per 1,000. So on our practice scorecard, you'll see the number of touches a practice has with their Medicare member. And some of our practices are okay, 2.5, 3 visits per year. For someone over 65, maybe that's okay. The practices that had between 4 to 5 visits per year for their Medicare members were the most successful. Had the lowest ER utilization, lowest inpatient admissions, best quality gap management, you name it. So touches are very important. Again, got to go back, have access in order to have those touches. So that was critical to find where we needed to be. And then you have to have those feet on the ground, coming back to those population care managers. They could see and feel and hear the pain points. What do we have to bring solution-wise with this innovation to take care of that pain point and this pain point? So unless you've got feet on the ground, unless you're listening, unless you're really hearing this through, do not and don't do the mistake of saying, well, it worked over there and they implemented it, and let's just implement it then top down. Let's get it going, get all the approvals, get the infrastructure done, and flip the switch and turn it on. It might have worked over there, but healthcare is local. Mm-hmm. You've got to figure out what your pain points are and everything else. So bottom up pain points and access, all critical. But you named it a little bit earlier. What's now the number one thing you have to do is you will have to unburden your physicians. We found out, about 3-4 years ago, obviously COVID, post-COVID, the burnout was already hitting us before COVID, but then it really accelerated. And some of these practices that were the strongest, most passionate practice you could ever imagine, and I could always go to them when I really needed to, could you try this out and see if it worked? They finally said, Jim, stop. I can't do it anymore. And it's like, it was so sad to see that happen. So we changed our priorities 3 years ago, and now we're seeing the fruit of that we went purely into what is the technology, the innovation, the workflow that's going to unburden the practice. What can we do inside that EMR and take away the noise? Take away the time it takes to forge through that EMR. How do we take all this data and distill it down to the most impactful thing that they could do, and only give them one thing to do, but put it right in at the point of care, in the workflow, when the patient's sitting right there. Have that pop up right in front of them in their EMR. If you're going to be able to do one more thing today, this is what you want to do. So all of a sudden, they don't have to forge through their EMRs. The information that they really need to know is very much put together in a very succinct way that they can access it. Again, it can be accessed in their workflow. They don't have to change workflows, because that's a whole other, a lot of energy, a lot of burden for changing things. Mm-hmm. So we implemented things that went after, quality management, again, coding accuracies, so that we could have the right prioritization of all our patients for what the resources they need. We implemented a lot of AI, more predictive, prescriptive type algorithms inside the data analysis. We went after behavioral health and pharmacy, pharmacoanalytics. All of these did not require a practice to add another person into the workflow. It did not add any time. It took away time. Doctors were coming to us and saying, well, I'm saving 30 minutes a day now. I'm like, okay. So you have a very happy doctor, and I'm going to have to boast a little bit, but our net promoter score that we measure every year for 2023, we hit a record, a 75 promoter score. Healthcare, you're lucky if you get around 58. maybe 60, 62. We were 69 last year and now 75 this year in 2023. So our providers who do that survey, our net promoter score, very high now through this unburdening and building from the bottom up, understanding what their pain points, doing it that way. And then our patient satisfaction, some of these tools, they're game changers. These patients are telling the docs that they're going to go and recruit more patients for them because they love coming to their practice because of this kind of technology that you use. Your secure testing platform now gives me access to you. And it's like, why not? So yeah, things have been exciting.
That's fantastic. A follow-up question when I think about what you were describing as the role from the bottom up and impact to workflow, how did you all involve the clinical partners, the representatives from the physician and the nursing team and medical staff in selection or in design? What role did they play? How did you include them?
As far as in the selection of these companies that we would bring in for their
Right.
innovations
From
and
a
solutions.
technology selection,
Yeah.
and let's say you select one, how involved do you have them in figuring out and designing what the new future state would
Yeah.
look like?
Yeah. It was a little different before this whole burden thing came on because we'd have much more availability, we'll say, of our physicians, and they were always very gung ho about population health, the medical home models, the specialty medical home neighborhoods, all these things. And that just, I can't blame them. They just weren't available as much. So we kind of moved towards having the key physicians representing them do pretty much the majority of the due diligence. So we go ahead, we first through the surveys and the evaluations, performance evaluations, we kept hearing certain things. Okay, here's our strategy for 2022 or 2023. We're going to try 3 technologies to introduce here that could maybe help. Maybe we'll get 2 of these 3 things accomplished. So we would evaluate the companies, the references. You have to, get multiple reference checks, and you have to actually go and visit. Don't just have a phone call and they
Okay.
say, "Oh yeah, it works great." No, show me, because you have to see it. You have to see the functionality. You have to see the ability to, whether it's dashboards or the analytics reporting outcomes, that it's working. You have to see operationally, do they have the right, quality assurance, processes in place? Do they have the right alerts in place, that when something isn't going to be available or something has gone off? That's too much to ask any physician to go and get to that level of the weeds, but you have to do it because, oh my God, in the last 10 years, I mean, the reason why we built our own data lake was because we went through 6 vendors. They all said they could do it, and none of them could. It was just a tremendous waste of energy and time. And so we kind of built it ourselves. But now we learned from our mistakes. We found the right, again, operational logistics that you have to have. These companies need to have not just the selling, but you've got to look at the middle management, the skill sets, the experience, and really make sure that these things happen. Then we come back, bring that, as we narrowed it down, we say to the user group, like we have a performance improvement committee of physicians, primary and specialists. Okay, we've gotten this far now. Now you got to tell us, is this really going to work? And here's a demo environment, okay, and try it out and everything. And so then they
Right.
get the hands-on, they see all that. Meanwhile, in parallel to all this, of course, you have legal reviews, compliance reviews, the IT system looking at the tech stack, you have cybersecurity, architectural reviews, everything you can imagine.
Mm-hmm.
That's
It's a
why
lot,
you
right?
that's why you only take on 2, maybe 3 at the most per
Yeah.
year. Don't spread yourself too thin.
How long would you say that timeline typically looks like? If you were a startup tech company coming in to work with a provider system similar to the makeup of Atlantic Health, let's say,
Yeah.
how long should they expect the selection and the procurement and vetting stage to take, right, to actually going live?
Yeah. Depends on a lot of factors and whether it's a high priority within, let's see, the entire health system strategic plan wants to do this, boom, So you may get a little bit more attention, a little bit more time saving in that environment. But yeah, you're looking from anywhere to 6 to 12 months.
I think 6 months that's
6 months is
that's
the
optimal.
quickest you're going to get.
Yeah,
Okay, six
agree.
months would be the quickest. Otherwise, I would normally plan 12 to 18 months.
Hmm.
Because if you're also looking at EMR integration, that's
Good
a whole
point.
other world then. Uh, so you've got to look at a lot of different factors of what you really want to do. I think in a non-EMR integration type of a project, you still would give yourself 9 to 12 months and you'd be somewhat safe. Yeah.
Okay.
But 6 months you'd have to really be hustling. Yeah.
Are you guys of the mindset to work in pilots and small rollouts? Do you tend to go in with I don't want to say a big bang. I don't think
Yeah.
most folks do big bang anymore, but how do you look at chunking up the work and ramping up the
Yeah.
rollout?
Yeah, we tend to. Most of them will. We really don't like to call them pilots because, we don't want people to sign up with the idea that they can get out of it.
I
Uh,
see.
a good
Semantics matter, man.
a good friend of both of ours actually, his message was, not the pilot phase, it's the landing phase. You land and then you expand, okay?
Okay,
But
okay.
but when you land, you don't go back, you've landed, okay? So I like that phrase. But
Land and expand. That's good.
yes. So yeah, we do tend to those start early adopters, volunteers, people who really want to try it out. Sometimes again offering certain incentives along with that, rewards, recognition for all that. But yeah, you have you try to, make sure you're using enough variety though, so that you're not going to be misled by your pilot. Okay, so because you
Mm-hmm.
have all just this type of practice, and wow, those 5 practices did fantastic. Look, there was no, this type of practice wasn't in those 5. We still don't know whether it's going to work. So try to give yourself a little variety when you go into, quote, your landing phase. And that way you can flush things out early and help the rest of the rollout go from there.
That makes lots of sense. And I would suspect too, in my experience, we were primarily dealing with one EMR and working through an integration. In many cases, depending on the mergers and acquisitions of a system, that provider may be working with multiple EMRs. And so
Yeah.
there's even a next level of complexity in the landing and expanding and having variations to prove out the concept and land and expand if you're dealing with multiple EMRs and platforms.
Hmm. Oh yeah. Now there's we have in our one ACO, majority of are all on Epic. And that's about whatever 1,500 physicians. The other 2,000 physicians are on 72 different EMRs.
72.
Yeah.
I feel like that might be a record.
So
I don't know if that's a
and
record holder you want to be.
I'm counting, of course, instances because
Sure.
you could be on eClinicalWorks cloud, but then you got one is on eClinical on premise, and then you got a different eClinicalWorks over there. So each we're within a project of extracting clinical data from the non-Epic EMRs. The Epic one, we get out of their Clarity database, can get extracts every single night, feeds
Hmm.
into our data system, and we're in good shape. We're looking at the ability to do that even real time, for trigger alert systems, things like that. So you can get, if you have one EMR, hey, God bless you, just run with it. Yeah, because when you're in multiple EMRs, the it's very complex.
Yeah.
Yeah, and you need help. You need a partner, a company that does this a lot. It is so amazing how even during the installation of an EMR, they may not turn on certain functionalities. That doctor, when they bought it for their independent practice, they didn't turn on the ability to put an NDC code in on with a medication, and you don't know that the patient's on a statin when you go into that chart because they never turned that on when they implemented. It's like, what doctor knows how to turn on and off coding for RX norm and NDC and all these other codes? The doctors don't
They
know
don't know
this.
that.
No. So when you've got different EMRs, it's not just the fact that you have 30 or 40 different EMRs. You've got a unique one, in all 72 of those EMRs.
Wow, that's a perspective that I have not considered, and it is really it's a little scary, and it underscores why implementing new technology, unproven technology or new to the system is so complicated.
Yes. Yeah.
For that being one of many reasons.
Yeah.
Let's talk about switching gears just a touch, but let's talk about the relationship with that partner, the vendor. If you think about all of the pitches and vendors that you have interacted with, some have turned into partners, some have turned into transactional relationships, others turn into strategic partnerships.
Mm-hmm.
When you think back on your experiences over time with these different types of third parties, what's one thing you would tell them to do differently, to handle differently, that perhaps as they go forward, it would be a small nugget for them to tweak in their pitch and their relationship building process and approach?
Yeah. I mean, there's a long list, of course, for your due diligence, skill sets, talents, experience, references, everything. But I think the one thing, there'll be thresholds that they have to achieve in each of those categories to still be on the table at the end of the day. But then it really comes down to the people, and not just their skill set within the domain of whatever their innovation or their company does, but it's almost like I relate it to with doctors. One of the most critical skill set a doctor can have is empathy.
Mm-hmm.
And, it's something that being burned out and, and time constraint and everything else, it kind of just goes away. And you don't have time for that. You don't have time to listen to your patient. And what does that patient want the most? They want you to listen to them.
Mm-hmm.
They want to trust you and respect you. The studies show that's the number one thing a patient is looking for right now is, yes, access is important, communication, everything, but trust and respect is number one. And if you don't listen and if you don't look them in the eye, I mean, it's like if your head's buried in that EMR, that patient's going to be like, I don't think he really cares about me. So the same goes for the vendors. Okay, I don't like to call any of them vendors unless they start to act like one. Okay,
Mm-hmm.
then I'll call you a vendor. But you want to be a true partner in trying to provide a solution to a pain point. You, as vendor, better understand that pain point better than I do.
Mm-hmm.
And understand it not just, again, in technical terms and what the solution can be, but understand the emotion behind it. That's what empathy is. It's feeling what the customer is feeling. So if you're going to develop, you're going to follow, Harvard Business School. I'm going to develop my customer value proposition, my CVP, and I'm going to go ahead and make sure that it fits all these different categories. Good, do that. But you better, when you come and talk, know what really is happening and the kind of frustration it's causing, and verbalize that you know that, because otherwise I'm kind of looking at you suspicious, like, I don't know if you really understand me.
Yeah.
I don't know if you understand our doctors and how important this is to get our patients to get this kind of care. If you're not letting me know that, you're gonna not be a partner. Okay, so I think that's critical. The understanding the pain points using emotional intelligence, not just business intelligence.
Mm-hmm. There's a few things that I heard I want to repeat back and validate and maybe talk a little bit about. in essence, the very first and foremost step, it sounds like that you're highlighting, is to listen.
Mm-hmm.
Ask questions, listen, and learn, and get to know me, get to know my problem, my pain points. Is that a fair
100%.
recount?
100%.
And when you do that, you may start. It's almost like the it's a phase that in a cycle that you go through. You may start out as we called a vendor, right, where there's really no attachment or relationship there. But the individuals that put that effort in to listen and to build their relationship and know your problem better than you do, evolve out of that transactional situation into a more relational
Mm-hmm.
partner,
Right.
and hopefully both end up having equal benefit as strategic partners to one another,
Mm-hmm.
right? That ultimate nirvana state of strategic partnership. But it's not a given. It's work, it's effort, it's over time, is my belief, that you reach that strategic partnership state. And in those situations where I'll speak for myself only, have sat where it's been extraordinarily transactional, that really tells me where we as a customer sit in priority. That's how it's conveyed to me, is how I representing the provider and prioritize, or how I'm thought about within that organization. And I don't think that is a productive foundation to build, upon for a strategic partnership.
Right. It's relationship 101. I mean, again, listening, building the trust. The experiences will keep building it over time, and I think the other advice I would have is, don't be afraid to tell patient stories from like your other clients or things like that. Patient stories are very powerful and they're
Mm-hmm.
real. And so, and if your product, let's say the main product is data extraction, okay, great. So that's all we need. We're going to put the data from all these different EMRs, put it over into this database, and we're going to develop nice performance reports, and great. We're going to hit our targets. Okay, that's nice. But, targets are patients,
Mm-hmm.
okay? You don't just say you're going to hit your insurance company target. No. Talk about how your product, your solution, solved not just a doctor's pain point, but improved a story about a patient. Anything you can do. This is what we're in the healthcare field here. You've got clinicians who had a calling to serve people, and that's been burnt out a lot, but it's
Mm-hmm.
still in there somewhere. Okay, and if you can really have the same, compassion to help people through your product, I mean, you're doing the right thing also. So let's go ahead and partner on this, and let's really make it happen. So again, don't hesitate to really, generate that value proposition, being not just dollars and cents and numbers and hitting targets. No, that patient's inside that value.
That's incredible. I haven't heard the value proposition presented and explained in that way, and I think that's really going to help and resonate with folks that are listening. At the end of the day, that outcome and that impact to the patient, if you're not telling that story back to the very people who went into their profession, to your point, because they wanted to serve people, like that is the ultimate connection point there. Thank you for that. Dr. Barr, what are you seeing in the current trends and the current landscape of digital health innovations, particularly in the healthcare space that we're talking about today? What are you seeing as really viable. We know that many systems are in an economic constrained environment. We also know that systems are largely dealing with uh, clinical shortages from a staffing standpoint. So perhaps the bright and shiny, really cool technologies are not possible
Yeah.
because of those constraints. What are you seeing as something that is really um, something that really presents a true clinical innovation that could make a difference and be meaningful in today's climate and
Yeah.
environment?
And again, when we say meaningful, I think we have to, of course, especially in today's environment, be meaningful financially as far as have some kind of return on investment there, because we know the challenges post COVID, the staffing challenges, the not only to find staff, but then the pay levels of eroding the operating margins, and it is not a very easy place right now in healthcare delivery for a lot of different components of the delivery system.
Mhm.
So we have to look at working, and this is where I think we've seen a few things. I'll divide it up into two different discussions. One is, where is there a good ROI though on when you're looking at total cost of a population, ER utilization, admissions, things that didn't have to happen, like your ambulatory care sensitive conditions that are being admitted. If they were better managed, patients had better access, better proactive care. That is something that we've seen big returns as far as in medication management. So that's like, all right, we only have for 500,000 people, we only have two ACO clinical pharmacists, only
Wow.
two. Yeah. And now we do get pharmacy students and interns and everything else, but still two. They have a 9-to-1 return on investment. I mean,
That's incredible.
it's just incredible. Medication management, what it can do for you. And so seeing that, we have signed on a pharmacoanalytics company that uses AI, and we're looking to help them act as not just two, because we can't find clinical pharmacists and we don't have the money to hire another one. So, but we want those two to make it look like they're 5 or 6 FTEs through the use of, again, the AI supported analytics that'll bring us in those 500,000 right to the top. Here is your next patient. That if you don't do something, this is the one that's going to end up in the ER, the hospital,
Wow.
be high cost, or have a bad event occur. So this way, the pharmacist can really prioritize their work extremely well using AI. So AI is very important. Medications, and then when you get into social determinants of health and behavioral health, why not? Everybody's using AI, and we do too, inside chronic disease management, evidence-based guidelines. What is this? What do we, how do we give clinical decision support? Yes, do as much as you can on that side. That's the other second part I was going to talk about. Use your predictive and prescriptive analytics. Right now, we're just finishing our work on chronic kidney disease, predicting which of our 500,000 people doesn't have CKD yet, but who's the next one who's going to get it? you know, and we have somebody who's got a 97% probability, just came out of our report. Okay, and this patient doesn't have a visit in the next 3 to 6 months. Whoa, let's
We need
do
to reach
something.
out, do the
Right.
engagement.
So working with whether it's clinical decision support supported by, again, the pattern recognitions and everything inside the data, that's very important with chronic diseases. But coming back, do that with your medications, do it with your behavioral health and your social determinants of health. Okay, those areas, and you got to do them all together really, because when you're doing the pattern recognitions, if you have the depressed person who has food insecurity and transportation issues, you know, and is on, you know, 16 meds, okay, now you gotta, it doesn't take an AI algorithm to figure out that that's a patient. You got to, but you understand what I'm saying. You bring in as many data features on your patients as you can from all domains, not just a claims database or an EMR clinical database. Take it from everywhere you can. Labs, medication, pharmacy files, Census Bureau, whatever you can get, zip code analysis. Bring it in, and then you're going to have the power of predictive and prescriptive, actions are going to be taken. So that's where I think right now saves you on the FTEs. Okay, so the chief financial officer isn't going to, be breathing down your neck. Whoa, 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 whoa. We're not making an investment in that company. Geez, what are you thinking? That we're made out of money? I go, okay, look, just give me this much time. I'll get a return on investment, and here's what it's going to be. So you do have to definitely, have credibility with that chief financial officer, and then at the same time, though, these have to help the doctors work smarter, not harder.
Mm-hmm.
So again, unburdening.
Mm-hmm.
And then the last part is try to use it be a mechanism where the patient is giving you the data features also. We forgot that there's a patient that we could have on, the patient's, cell phone. It's interacting with them and it's gathering information for you. Why not? You've got to get that information because that's really going to be more of your trigger alert system, which allows you to know real time when someone's deteriorating. Not waiting until a claim comes in, 60, 90 days later, or again, a lab result that you just haven't been able to put the whole picture together. Get information from that patient also. And so if we do all that, I think we can, those kind of innovations are going to save dollars
Okay.
on the upfront side as far as the FTE reductions, or at least not increasing FTEs. And then you're going to hit the shared savings and the bonuses and surpluses and all the other P for P stuff. So you're going to have the return, and obviously you're going to have good patient experience and outcomes. So the marketing department can go wild and
Oh, they would love
spread
that.
the word.
But your point is excellent, and get as much of the data from as many sources as you can. Don't forget the patient themselves, and use that collectively
Yeah.
for predictive and prescriptive. And I have to ask, you were intentional on predictive and prescriptive, not mentioning generative AI. Do you think we're still a little bit early on in Gen AI in the healthcare space?
Getting really close. And we haven't, we're looking at something that has a lot more guardrails around it that are going, I think is going to be a safer environment for us to go ahead and go down that road. But yeah, just be careful. Be careful.
I couldn't agree more. Thank you so much for your insights and thought leadership today and what all you have shared and your experiences as well. As we come to a close, is there anything additional that you want to share or that we didn't cover, and be a part of how we wrap this up and land the plane and set forth to expand to all those who are watching?
Good question. There's so many things love to share, and I'd love to learn from your audience. Actually, but I appreciate you allowing me to share as many of your other events. I'll learn from them. But sharing is probably the best message because this, we get hit with different challenges every day and new barriers and new problems and trying to find really good partners. I'm not going to name some that haven't been good partners, but we need to begin find the partners who have, going back to what I said, the right focus, the right vision.
Mm-hmm.
It's getting that patient to get what the care they need. If we could keep sharing our ideas, our methods, our visions, I think that's the key. I think there's so many exciting things, and when I hear from other health systems, things that are going on, I have a new pilot that you know about, which I haven't really released yet, but regarding people's spiritual health. Why not go for the body, the mind, the social, and the spirit? All four of those can reflect, can impact a patient's outcomes. So things like that. Think out of the box, share things, and certainly, I guess my contact information will be available for people. I would say do as much sharing as we can, because we still have a long ways to go. But along the way, even if you just share some good patient stories, beautiful.
I love that. We encourage everyone to share your stories, share your learnings, and we can make a difference. You can make an impact. You can be a part of that. It's a big ecosystem, but I enjoy being a part of that ecosystem and what little impact just one person, myself, can have on making it better. Imagine if everyone shares and makes a commitment to make it better, what that would be from a force multiplier. So thank you for that encouragement and the call to action. It's a wonderful call to action to our audience. Thank you all for being with us. We wish you well. Have a great day.
Thanks, Amber.